Hello, I'm Dr. Karuna, obstetrician and gynecologist at Akkineni Hospitals. Hope you're in good health. Today, we'll cover some key information. Stay with us and note it down.
This animated diagram represents the pregnant population of India. Instantly, 52% of these data points transition into a warning red. National health surveys confirm that over half of all pregnant women in the country present with clinical anemia. To understand exactly what that red zone means, we have to establish the clinical thresholds for the disease. During the first and third trimesters, a patient is diagnosed as anemic if her hemoglobin drops below a rigid baseline of 11 grams per deciliter. In the second trimester, that diagnostic baseline dips slightly to 10.5 grams per deciliter. The most critical space on this graph lies further down. Any reading that falls below 7 grams per deciliter enters the territory of severe anemia. This specific severe presentation complicates up to 5% of all pregnancies nationwide. It is a primary driver behind 3 distinct outcomes: maternal mortality, preterm birth, and low birth weight. This 52% prevalence rate represents the predictable result of massive physiological demands colliding with systemic pre-pregnancy depletion. Pregnancy initiates an aggressive spike in the demand for elemental iron, a demand so high that the human body cannot naturally offset it. The developing maternal fetal unit acts as a continuous structural drain on the mother's existing physiological reserves. In a non-pregnant state, a woman's baseline iron stores might maintain equilibrium, but gestation rapidly accelerates those metabolic requirements. Without pharmacological intervention, the gap between what the body requires and what the environment provides becomes an insurmountable deficit for most Indian women. To prevent severe morbidity, clinicians must stop treating mild anemia as an expected symptom of pregnancy and start managing it as a high-stakes equation of supply and demand. This diagram illustrates physiological hemodilution, the primary driver behind changing hemoglobin concentrations during a normal pregnancy. We start with 2 side-by-side cylinders at equal baseline ratios, the numerator representing red cell mass and the denominator representing plasma volume. Starting in the first trimester, maternal plasma volume begins to expand. By term, this denominator increases by roughly 50%. The maternal red cell mass also increases, but stops short. The numerator only grows by 25 to 30%. Even if a patient has perfectly adequate iron stores, her overall concentration of hemoglobin falls. The fluid volume simply outpaces the red cell count. This dilutional drop is an entirely normal, protective evolutionary mechanism designed to reduce blood viscosity. Reduced viscosity optimizes placental perfusion, ensuring adequate blood flow and nutrient delivery to the fetus. The clinical complication arises before conception even occurs. Over half of all Indian women enter pregnancy with a pre-existing iron deficiency. When physiological hemodilution is superimposed onto genuine pre-existing iron depletion, any metabolic buffer is destroyed. This double hit accelerates the drop in hemoglobin, pushing the patient rapidly toward the severe risk category below 7 grams per deciliter. Because hemodilution is an unavoidable feature of a healthy pregnancy, the fluid expansion cannot be stopped. The only controllable variable is the systemic correction of the iron deficit. We map this deficit precisely. A healthy pregnancy requires an additional 800 milligrams of iron. The first allocation is non-negotiable. 300 milligrams is shunted directly to the growing fetus and placenta. The remaining 500 milligrams is required exclusively to support the expanded maternal red cell mass we just discussed. This demand curve steepens significantly over time. By the third trimester, the daily iron requirement reaches between 7 and 10 milligrams. Now look at the asset side of the ledger. A typical Indian diet provides a maximum of 2 to 3 milligrams of absorbable iron per day. The disparity is stark. The biological demand requires up to 10 milligrams daily, but the dietary intake caps out at 3. No amount of dietary modification can close a deficit of this magnitude within a strict 9-month gestational window. Because physiological absorption limits make dietary correction impossible, universal pharmacological supplementation is the only mathematically viable solution. While iron deficiency dominates the equation, the accelerated cell division of pregnancy also drains other vital stores, primarily folate. To counter this, the standard government iron folic acid program requires 500 micrograms of daily folic acid. This prevents megaloblastic anemia and neural tube defects. Vitamin B12 deficiency is also frequently seen alongside iron deficiency, particularly in populations with high rates of vegetarianism. Clinicians must also conduct antenatal screening for genetic hemoglobinopathies, such as the thalassemia trait, which is highly prevalent in Western India. Folate, B12, and genetic traits all require strict management, yet they operate in the shadow of the massive iron deficit threatening every pregnancy. The clinical misconception that mild maternal fatigue is just a normal symptom of pregnancy is highly dangerous. When a patient's hemoglobin drops below 7 grams per deciliter, the mother's cardiovascular system suffers from a lack of oxygen-carrying capacity, causing cardiac decompensation. This depleted red cell baseline drastically reduces a pregnant mother's hemodynamic tolerance to sudden blood loss during delivery. This reduced tolerance is explicitly linked to increased mortality rates from postpartum hemorrhage, the leading cause of maternal death. The consequences extend equally to the fetus. Fetal iron stores are primarily established during the crucial third trimester. A severe maternal deficiency directly starves the fetus of the iron necessary to synthesize basic neurotransmitters. Without sufficient elemental iron, the critical process of myelination halts. This leaves early brain and neurodevelopment structurally impaired. A failure to manage the maternal iron balance sheet results in immediate lethal risk at delivery and permanent intergenerational neurological deficits. Catching the deficit before it reaches the critical threshold requires a systematic antenatal monitoring timeline, mapping assessments at booking, 28 weeks, and 36 weeks. The first-line defense is universal daily supplementation with 60 milligrams of elemental iron and 500 micrograms of folic acid throughout pregnancy. To address compliance barriers due to gastrointestinal side effects, practitioners should instruct patients to take these tablets at bedtime or with stool softeners. When oral supplementation is unabsorbed or rapid correction is needed prior to term, the protocol moves to the second-line escalation, intravenous iron. Formulations like ferric carboxymaltose and iron sucrose are safe, effective intravenous options during the second and third trimesters. The final line of defense is whole blood transfusion. This is strictly reserved for symptomatic severe anemia near term or active cardiac decompensation. Because the physiological math guarantees a deficit, practitioners cannot wait for clinical symptoms to appear. By rigorously tracking the mathematics of hemodilution and iron demand, clinicians can intervene early, turning a leading cause of maternal mortality into a preventable complication.